Reshmi Haridas to take over. She will be speaking on viral keratitis. She is currently working as consultant in Government Health Services, Trivandrum. She has done a fellowship at Arvind Tirunelveli in cornea.
Thank you, Sanjana. So I'll be dealing with viral keratitis, but basically just herpes simplex because I just got time for that. So a word about the pathogenesis of herpes simplex virus. We all know that the problem with herpes simplex is its latency, and that results in the recurrences. So the primary infection is usually through the eye or the oral or the cutaneous route, in which case there's a retrograde transport of the ocular infection through the nerves, and it reaches the ganglion where it replicates and results in latency. And later on, when there are certain trigger factors, this can come back into the eye and present in the form of the recurrent herpes simplex virus, which we usually see clinically. So there are many trigger factors, some of them psychological, physical, contact lens wear, some topical steroids even, sun exposure, etc. So I think I'm not going to the details of that. Coming to the next, primary ocular virus, ocular herpes usually in children and adults, young adults in the form of blepharoconjunctivitis, cutaneous in the form of rashes, and oral in the form of ulcers. So by about young adulthood, almost all of us would have got a primary ocular infection, and many times it's just asymptomatic. So there are several classifications for recurrent ocular herpes, so I'm not going to the details of it. So basically the next slide. I'm going with the anatomical way of it. So the epithelial keratitis, I think this is the most common thing that we see in the clinical setup as corneal vesicles, which we can call as punctate epithelial keratitis or superficial epithelial punctated keratitis. Then we have the classical dendritic ulcer, which has got the linear ulcer with terminal bulbs and swollen epithelial borders with live virus and takes up the fluorescent stain. We can even use the rose Bengal staining, but not if we are planning for scraping because it's lethal to the virus. We have to often differentiate it when we are faced with a dendritic ulcer from pseudodendrites, especially herpes zoster virus, in which it's a superficial lesion with, it's not an ulceration, without terminal bulbs or central ulceration. And of course, and finally we have the geographic ulcer, which is, we know it's a coalescence of the dendritic ulcers, and again it's a true ulcer. The treatment for almost all epithelial lesions is a topical antivirals for about 15 to 21 days and not more than that, with topical antibiotics and preservative-free lubricants. A common question is, should we use topical steroids? It's a no if it's a herpes simplex virus. And usually you know herpes simplex virus is a unilateral presentation, so by that we can usually judge it. There is a different type of dendritic ulcer I mentioned about, is a marginal dendritic ulcer, which behaves a little slightly different because it's marginal, and so there's a lot of inflammatory exudate there. Probably in that situation, maybe we'll think about adding a low dose steroid. Coming to the next thing is, it's not exactly a keratitis but a neurotrophic keratopathy. So if you see an ulcer after about 15 days, like 15 days of antiviral, if you see an ulcer like this with a smooth ulcer with the rolled out edges, so we have to think about neurotrophic keratopathy. It's basically because of a damaged basement membrane, so that the epithelium is not healing. And there's always antiviral toxicity in this. And the third thing is neurotrophic component because of the entire neural component of this ulcer. So the treatment is based on this, that is, we have to withdraw all antivirals the patient is on, profuse preservative-free lubricants, and we can also treat it by bandage contact lens, but the patient should be on observation. And we can plan an EMG, but a tarsography itself is a very good treatment for neurotrophic keratopathy. And always add doxycycline, because once the epithelium is out, stromal melt is a risk. I think this algorithm is something that's good that you can follow. That is, in a case of personal ulceration and herpes simplex keratitis after 15 days. So first thing is, we have to confirm whether there's an infection. Of course, if there is a secondary bacterial or fungal infection or it's a primary viral infection, we can always resort to a PCR. So if there is a laboratory evidence of active infection, then we have to look for the compliance of this patient. And if the compliance is good, then we have to think about antiviral resistance in these days. So we have to plan an alternative antiviral. But if there is no laboratory evidence of active infection, so probably what we're dealing is a neurotrophic keratopathy like what we discussed just now, or an unrecognized stromal involvement, in which case we have to add a topical steroid. Coming to stromal keratitis can be because secondary from an epithelial or an endothelial, but what I'm dealing with here in this slide is actually a primary stromal involvement. So when we see a case with stromal edema with vascularization or without vascularization, which is the first setup, we have to think about a stromal keratitis. the corneal sensations might be decreased, all that will be there. We have to stain this patient to recognize two components of stromal keratitis, which actually their treatment is completely different. So if there is no ulceration on the right side, what I'm showing is, if there is no ulceration, then what we are dealing with more commonly known as the interstitial or the immune stromal keratitis. Basically what happens here is it's an inflammatory antibody complement cascade, and so the treatment over here itself is topical steroids in high dose, about 6 times 1% prednistate, and then according to the response we can taper it, but taper it about at least for about 10 weeks, and always with an antiviral prophylactic coverage of 400 milligrams BD. The other one is when you have an ulcer on top of that, so always do a corneal scraping. You rule out a secondary bacterial or fungal or acanthamoeba in this, and of course send for a PCR to know is this a herpes simplex virus that we are dealing with. Because in this case we have two things here. There is a virus is replicating actively, and on top of that we have a high inflammatory, severe inflammatory response. The treatment is very difficult in this case because we have to give steroids but at low dose about 2 times, and at the same time a high dose therapeutic dose of acyclovir, actually the dose is wrong on the slide, is 800 milligrams about 5 times initially, and then taper it. You have to go on for about 21 days and look at the response and treat it accordingly. So all what we do, finally we get something like this, a corneal scar with vascular, the characteristic vascular thing is there. Finally, coming to the endothelium is again what we have clinically is a stromal edema, but how will you differentiate this from stromal is that there will not be the typical vascularization, and look carefully under the stromal edema, you will be able to find the KPs. So in that case, it's a primary endothelitis, and you have linear, diffuse, and the characteristic deciform endothelitis. And treatment for this is topical steroids, about 6 times, and an oral antiviral coverage for this, and continue the oral antiviral as long as you have the steroid use. In all these cases, steroids, if you're starting, taper it very slowly over 10 weeks. A common accompaniment of herpes simplex virus keratitis is iodocyclitis and trabeculitis, and trabeculitis especially, we have to keep a lookout for an intraocular pressure, so keep checking the intraocular pressure every week the patient comes to. If it's an acute stage, then topical steroids is very good, but if it's chronic, probably it's because of the trabecular meshwork blockage. In that case, probably we have to think about a surgical thing. Coming to the diagnosis, you know that it's basically clinical, but there are certain situations in which we have to go for a laboratory diagnosis in case of an absence of a classic dendritic pattern or a necrotic stromal keratitis or prior to keratoplasty. We can resort to a lot of things. Viral culture is considered to be gold standard, but most of us don't have an access for it. So we have PCR and IFA, which has come a long way in helping us. Especially PCR, because it has got a high sensitivity and specificity. Actually, IFA has got a better specificity, but the equipment is quite costly, but PCR gives a high specificity, sensitivity, and accuracy. And now we have the multiplex PCR, in which we have a battery of viruses can be checked. We don't have to specify which virus we want. So in a small time, we can get what virus we can actually know if it's virus and which virus we are dealing with. We also have to know about the newer antivirals, because now is the era for antiviral resistance. So in case of topical, we have got 2 things, acyclovir and ganciclovir. In oral, I'll just take 30 seconds more. It's val-acyclovir we can have, or val-ganciclovir. The others are foscan and famciclovir, but the dosing schedule is different, and the safety profile is also a bit problematic in these cases. Finally, a word about topical cyclosporin. Even this has come a long way, both in case of stromal keratitis that are dependent on steroids, and also as a primary modality for stromal keratitis in various doses, 2%, 0.5%. They have studies which show these are effective. Keratoplasty, sir has already dealt with, so I'll just skip that. Prevention of stromal recurrence, this is a big headache for clinicians as well as for the for the patient, because it comes back again and again. And we know the last thing that we resort to is an oral acyclovir for 400 milligrams BD. In many patients, we have to give it for over a year, especially for keratoplasty and all. But the problem here, if you give it for that long, you have to deal with acyclovir resistance. So I think there are so many studies on both sides. So the basic consensus is giving 400 milligrams BD for 1 year and not more than that if possible. Thank you.
Thank you, doctor. That was a very vast topic, concised into this short span of time. Now